Hi there, welcome back. Now, being observant manual therapists, I know you all are, you will have noticed that we have a new model with us. This is Nora Fultz, and I thank you very much for helping. We're going to be looking at the hip in this final segment on this volume, and the hip is relatively easy to assess biomechanically because it doesn't really have any arthrokinematics other than distraction, so that it doesn't matter which way you try to glide this the femur, it ends up coming laterally, so it's a distraction test. But looking at the actual the mobility test in this joint, we'll look at physiological movement and try and keep it as specific as possible for the hip joint. Okay, so we'll have the patient lying down if you would. And we're going to be using a very long lever and trying to stabilise over a very short lever, so it's going to be very easy to overcome your stability to the test. But you basically try to resist the movements that are occurring. So as I test flexion, the innominate will want to rotate backwards, so I will put my hand on the ASIS and hold the innominate down and then flex up and get the end fill. And if I push too hard, then I'll simply overcome the resistance. So it's just up until I feel the end fill. I can test the same way for medial rotation, stabilise holding the ASIS out and rotating medially. And for lateral rotation, just change my grip a little bit so I can lever through the lower leg, hold the ASIS in and rotate laterally. For abduction, it's a little easier for me to test this way. Come towards me a little bit, Nora. And stabilise the pelvis by holding it down and abducting the leg on the stable femur. Alternatively, we could have the patient laying on a side into this position and again stabilise the innominate here and abduct to feel that range of movement there. Lay on your back for me. Thank you. Adduction we'll test by again stabilising the innominate there. Sorry, adduction, my fault. Stabilising the innominate by holding it up and just bringing the leg in towards the midline and again feeling that end fill. Particularly soft one that, so again don't push it too hard. For extension, lay onto your stomach for me. We'll have the patient laying prone and come towards me a little. Stabilise the ischium now. Put your hand right down on the ischium and push the ischium down. Don't push the iliac crest because you'll force that into anterior rotation. Hold it down here and then hold underneath the leg. Keep the knee extended so you're not testing the rectus femoris, and then just lean back and feel the range of movement of extension at the hip. Like so. Thanks. Flip onto your back again for me. We can also look at quadrant testing in the hip as a mobility and a stability test. And the common quadrant that's taught is the internal flexion quadrant, which is an internal rotation of the femur, adduction, and then flexion. And you're looking for that normal ovoid of motion, like so. And it can be done with and without compression. If I compress, I simply push down the line of the femur as I do the test. Without compression, there's a small blip in the ovoid. With compression, it should be a smooth arc. We can do the lateral quadrant as well into this position. Again, stabilising the innominate, holding the leg into lateral rotation and abduction and flex. And this is actually the quadrant that contains the Faber's position. Flexion, abduction and external rotation. Lay on your stomach for me. We can also test extension quadrants as well, and the medial rotation adduction extension quadrant is a particularly pertinent one, as it's one of the earliest signs of arthritis, or at least a limitation of arthritis. So again, stabilising the ischium, if I reach way underneath around to the lateral aspect of the femur, and I simply come up, so I bring it internally, medially rather, and as I bring it up, it automatically medially rotates the leg. For lateral rotation, I'll do it on this side, reach underneath, grab the medial side of the thigh and simply extend and abduct, and it will automatically laterally rotate. Lay on your back for me again, Nora. To test the arthrokinematic, the only movement we can really test is distraction. And we'll test this in the resting position of the hip, about 70 degrees of flexion, a bit of lateral rotation and a bit of abduction. Come in as close to the groin as you can with your hands. Put the leg back where it should be in that rest position, and then you simply distract very gently, remembering that the plane of this joint is anterolateral. And you're not looking for range of movement here, but rather is it a nice normal end feel, or is there a stiffness as you're doing it? So these are the main mobility tests of the hip. When we look at treatment, because there are no real glides to speak of, the only time you'll use the arthrokinematic will be when there is pain. And we can use the same arthrokinematic and grade it with a 1 or a 2 to reduce pain. For more direct stretching, it's really best to use a stabilization belt where you'll come down for flexion, for example, and belt it so that the ASIS can't rotate backwards. And then with the innominate stabilized, we can come into this position, do the hold relax techniques, and simply stretch it in that direction. Probably the most common movement you'll want to regain for extension of the hip is, is extension and medial rotation. This is the one that is commonly lost, and it's the one that affects walking most and may be disruptive to the lumbosacral joint and the sacroiliac joint. To stretch this one, lie on your stomach for me, it's best if you let gravity and a bit of force do the work for you. So we'll use a sandbag again and bring the hip into the extended position, like so. We'll use the pillow just to support the lower leg. There. Using a stabilization belt, strap it across the ischii. Okay, so the ischii are held down and the hip is held in extension. You can then apply a muscle stim to the gluteus maximus, put a hot pack over that, and simply leave them there for 30 minutes or so. At the end of the time, come back, take the hot pack and the muscle stim away, and then the easiest stretch here is to simply come onto the shaft of the femur and force that forward to stretch the capsule, or onto the ischium and push this down to further extend the hip, like so. And this is a very effective technique to regain extension, and you can really look at regaining probably 20 or 30% of the movement in one treatment. Generally speaking, the hip isn't a symptomatic area, and it's very rare for the patient to actually come in complaining of pain in the hip. But it is commonly treated because it is a point of origin of a number of low back problems. And from personal experience, if I have a patient who's walking in with an unexplained hypermobility or instability in the SI joint, then I will certainly be looking at the mobility of the hip.